Welcome to Diabetic Retinopathy. What is it and are you at risk? At Diabetes Eye Health, my name is Casey Kaufman and I'm pleased to serve as moderator for this program. I'd like to introduce our presenter, Dr. Timothy Murtha, a clinical instructor in ophthalmology at Harvard Medical School, who also treats patients at Joslin Diabetes Center in Boston, Massachusetts. Dr. Murtha will talk to us about what patients with diabetes can do to reduce their chances of getting diabetic retinopathy. He'll also talk about how patients with diabetic retinopathy can keep their disease from getting worse. This is important information for patients with diabetes to keep in mind, as it may help to protect your eyesight for years to come. Again.
Thank you, Casey. It's a pleasure to be here, and we'd like to cover some of the topics to help you protect your eyes. Let's start with just a quick review of some of the material that Dr. Schlossman has shown us. On your left is a photograph of what the normal retina looks like, and it's labeled as you had seen before. And on your right is the picture of the retina that has the abnormal diabetic changes. What you need to understand is that the retina is much like the film in what cameras used to have years ago, before we went digital. If the film in your camera was abnormal or defective for some reason, when you got it developed, you got back blurry, distorted, abnormal pictures. The same is true for the eye. We can use the same analogy. If the retina in your eye is injured for any reason, be it diabetes or other problems, the image that sends to your brain is garbled, blurry, abnormal. And it makes reading, driving, pursuing your activities very difficult. This is exactly what we're hoping to prevent. So, can we prevent it? The unfortunate answer to this question is we cannot prevent it in 100% of cases. There's a large but here. But we can alter the course of diabetic retinopathy and the development of diabetic retinopathy. And there are things that we would like you to take away from this evening that can help guide you through this. So I'd like to take the next few minutes to discuss these with you. The first is, as has been touched on earlier, regular eye exams. This is one of those points that we really can't make frequently enough. Many people are frightened. Many people find this to be a difficult exam, but really it shouldn't be. As we have heard, diabetic retinopathy can develop before you have symptoms. Therefore, we can't depend on you to tell us when there's a problem. We can only find it by looking. And if we can't look, we don't know where we are. It's in essence flying blind, if you'll pardon the pun. By having your eyes dilated on a regular basis, your eye doctor, preferably a retina specialist, can ascertain the degree of retinopathy that is present and formulate a plan so that you can be treated appropriately. Beyond this, the second thing that we can do is medical care. This is a broad category, the whole topic of treatment. In my mind, treatment really means prevention. That's what this is really all about. In diabetic retinopathy, 1 ounce of prevention is worth many pounds of cure that we can deliver. So let's talk about how we might prevent this. The first and foremost is sugar control. And I can't emphasize that enough. It's sugar control, and sugar control. Beyond that, as Dr. Schlossman indicated a few moments ago, other conditions that aggravate diabetic retinopathy need to be evaluated and treated appropriately. And these include blood pressure, cholesterol, anemia, renal disease, and other conditions. It is very important that you work closely with your primary care doctor or your endocrinologist to address each of these questions. Not a day goes by in my practice where I'm not asked, why is blood sugar so important and how do we really know that it's important? Well, a little history is important here. This was a raging question in medicine 35 years ago. There were 2 very active camps in organized medicine. One camp felt that aggressive sugar control was absolutely necessary. The other camp felt that a much more laissez-faire approach was acceptable. This became a problem for public health officials in that our patients were being given mixed messages. They would see one doctor and ask to strictly control their sugar, whereas they would see another doctor and be told that such tight control was not necessary, and the only thing they really needed to do was to prevent diabetic ketoacidosis. The public health officials recognized this, and the NIH stepped in, and they helped to organize the Seminole Trial that looked at the effect of blood sugar upon diabetic retinopathy and diabetic eye complications. And this was known as the Diabetes Complication and Control Trial. And it was commenced in 1985, and it was run through multiple medical institutions across the US. The design of this study was really quite simple. It took two groups of diabetics, and it asked one to maintain their hemoglobin A1C, that's the measure of your blood sugar control, at a level of 9. Now, by today's standards, 9 seems quite high, but in 1985, 9 was considered standard control. It took a second group of patients and asked them to control their blood sugars at a hemoglobin A1C level of 7. The study was able to keep these people well controlled at these levels throughout the course of the study. These individuals were then followed over the course of 9 years for this study, and they were asked to come in for routine eye checkups several times a year. And at these visits, vision was tested, the eyes were examined, levels of retinopathy were attained, treatments were carried out if that was appropriate. And the two groups were followed over the course. Early on, it became quite clear that the individuals in the hemoglobin A1C group of 7 were doing quite a bit better than those in the 9 group. They were having fewer treatments, retaining better vision, having less complications, and overall doing much better. The study was actually designed to run for 10 years. After 9 years, the individuals in charge of this study, those running the study, were so compelled by the results, the dramatic nature of positive response to good blood sugar control, that they had to stop this study on ethical grounds. They felt it was unethical to allow those individuals in the hemoglobin A1C group of 9 to remain treated at that level and not bring them down to A1Cs of 7 for their own benefit. In addition, they felt compelled to stop it early so that they could report these results to the medical community at large and allow the question of control to finally be answered in a definitive manner. So this is the turning point where we knew that sugar control was important. We as physicians recognize the burden it is upon our patients to maintain tight sugar control, but now we know that it is worth every effort that you can apply to sugar control. Just as an aside, we run many trials and many clinical experiments over the large portion of medicine. It is extremely rare that we ever stop a trial for positive results. In fact, this is probably the only trial I can think of that was ever stopped for this reason. The vast majority are stopped for poor results, for complications, for adverse, unplanned problems. That just tells you how dramatic sugar control really is. Okay. So, with that information, the NIH has now looked back and found that with good sugar control, with appropriate eye examinations on schedule, with timely care, and ultimately good follow-up, we can reduce the risk of severe vision loss by over 95%. That's absolutely dramatic. Once again, from personal experience, when I started my career in ophthalmology and diabetic eye disease, it was not unusual to look into our waiting room and see individuals with guide dogs, canes, attendants, wheelchairs, etc. Over the course of the ensuing 25 years, this has become a rare sight in our waiting rooms. That's how much progress we have made. And much of this can be attributed to medical management, blood sugar control, medical care. That is not to say that there are not treatments, ophthalmic treatments, that are very beneficial. And these too fall under the broad headline of treating diabetic eye disease. They are also looked upon as preventive. Tonight's talk is not designed to discuss the treatments that are available, but suffice it to say that they are highly effective, and when appropriate, they are absolutely for your benefit. So, how can you take this information and incorporate it into your daily life so that you can achieve these type of results? Well, we've created a little acronym, and we call it Keeping on Track. The T stands for Take Your Medicines. I can't tell you how many times every day I see people who are not taking their medicines or not taking it correctly. This is a problem that should not be allowed to happen. Talk to your doctors. If the regimen you're currently on is not working for you, there are many ways to skin this cat. Very important to take your medicines. Next, R. Reach and maintain an adequate, healthy weight. In the US, and in fact across the world, we are in an obesity epidemic. In fact, obesity is the cause of the spiraling cases of diabetes across the world. So anything you can do to help manage your weight will help managing the sugars much easier and will help you do better in the long term. A. A stands for adding physical activity or exercise to your regimen, to your daily regimen. By exercise, we don't necessarily mean doing a triathlon, but unfortunately in the US we've become extremely sedentary. We need to get you out and moving. Exercise provides many benefits. First off, exercise alone will cause your blood sugars to come down. Next off, exercise will help you lose weight. By losing weight, you're going to have easier control of your diabetes. There are individuals who, if they lose sufficient weight, will no longer even be diabetic. Exercise increases perfusion, helps the blood flow through your system better, helps get blood to areas that need this blood. And lastly, exercise releases many positive chemicals in your system that help you be healthier. So please incorporate exercise into your daily routine. Control. Well, I think we've beat this one over the head. Control of any medical condition really makes a difference. Lastly, K stands for kick the smoking habit. Smoking does no favors for anybody in any manner, but in diabetes it does several things that are quite deleterious. A, it ties up the red blood cells with carbon monoxide as opposed to oxygen, decreasing the oxygenation throughout your system. B, it's damaging to the small blood vessels throughout the system, including those in the eye that we have seen earlier. We don't need to aggravate what's already a problem. C, smoking elevates blood pressure. We already know that that's an aggravating factor, and we really don't want to do that anymore. By incorporating these into your daily regimen, we think that you too can decrease your risk of significant problems from diabetes and diabetic eye disease. Thank you.
Thank you to Genentech for their support of this educational program. I'd like to remind you that additional videos are available at diabetesEyehealth.com. Thank you so much for joining us.